Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This week, we are talking to Dr. John Quinn. John has been part of our teaching faculty for quite a few years, and we are both here at the DemiMed conference in Dusseldorf. John, welcome to the program.
Thank you so much. It's great to be here.
You are a difficult man to chase because I have been trying to get you to sit down for ages and have this talk, and it's only because I'm holding your pints hostage until we can get you to have a chat. So tell us a little bit about yourself.
Yeah, definitely. So thank you for the opportunity to discuss and chat. I started out as a paramedic in North America and worked in the Middle East and in Europe, and graduated from Charles University as an emergency medicine doctor, and then was fortunate enough to go to Peru, actually, and then did my residency training in emergency medicine in both Ireland and the UK, and now I practice in the UK and work quite a bit in Ukraine and elsewhere around the world.
So you have been on the forefront of austere medicine for ages. Tell us about your experience in austere medicine, why this is your passion, and what are you doing?
Yeah, sure. So pre-hospital medicine is certainly very challenging. It's also very rewarding. Working in a hospital is also rewarding as well, being able to treat patients and provide best practices, but also having to think outside of the box and provide best practices, the best that you can in a pre-hospital environment, in an austere environment, is something that is, every patient is a little bit different, has a little bit different a challenge, and being able to, bring the highest level of care that we can into the pre-hospital space is something that has turned in serendipitously into really the last 20 years or so of my professional career.
So we met in Malta in 2014?
Probably, yes.
Maybe
yes.
2015, when you were the medical director for MOAS, and I was the chief paramedic for MOAS on their offshore migrant ship.
That's right. I was probably listed as their chief medical officer at the time. I was working for their for-profit company, Tangiers International, but I would give a lot of advice. I would do a lot of their things for their nonprofit, which is MOAS, Migrant Offshore Aid Station. They had a great project there. They had a lot of their own medical teams that they did include me, and sometimes did not include me with a lot of the procurement and training and SOPs. But yeah, that's right. I think it was in 2014, 2015.
Since then, we've been running into each other. You invited me and Dr. Winston to Prague for a conference in global health.
The Prague Center for Global Health Forum. I think that was 2016 or so. Yeah, that was a great event. We did it every 2 years with the idea of bringing together sort of disparate backgrounds: military medicine, humanitarian medicine, academic medicine, and really trying to promote the concepts of health security and really pre-hospital medicine in general.
And then we keep running into each other in conferences. No, you and I met at the Extreme Medicine Conference in London.
2012.
In 2012. And
2012, yes,
because
that's
we've been
right.
emailing back and forth.
That's right.
And we were looking at this tourniquet lecture.
Yes, there was, yes.
And then basically you were making a comment, I think I was making a comment, and we looked at each other and like, wait a minute, you're John Quinn.
That's right. And you went up to the front of the thing and trying all the different tourniquets on in different times and things, I remember. That's right. That was 2012. That was the first World Extreme Medicine event that I went to, and that was actually in the city of London before it kind of shifted to Edinburgh.
Right.
And that was a great event. And if you think about the differences in pre-hospital medicine from 2012 until 2022, let alone now 2023, I mean, a lot of things have stayed the same. Some things have changed, drastically and dramatically, and some huge gaps and challenges still remain.
That was 2 years before the war, and you were already in Ukraine. So tell us about your experience in Ukraine, and when did you start going there?
I was fortunate enough to be invited on a humanitarian medical mission in 2001. So I had gone to Macedonia to do some medical volunteering. It was very limited in scope. I was an EMT, and at the hospital I was working at in the western suburbs of Chicago, they said, we're going to go to Ukraine and do this medical mission. And I understand you just came back from Macedonia, so maybe you want to come with. So self-funded, it's very expensive to go all these places, and went there. And that was the first start of really engagement with Ukraine on a medical side. While I was there, I was doing a whole lot of sort of paramedic EMT level training with their pre-hospital providers. I was able to arrange a few ride-alongs with their ambulance crew, and see how pre-hospital medicine worked there. It was very interesting and very eye-opening. You imagine in 2001. And then I was able to come back and bring some defibrillators and some other training equipment, and did a lot of engagement activities. And I also met a lot of representatives at the time. They were preparing for the September NATO event that takes place in Western Ukraine on a biannual basis. And so I was able to engage with them, and that kind of led to a whole lot of other activities really since 2001. And I was fortunate enough to be able to have a lot of experience in Ukraine and see the sort of evolution of healthcare and the sort of process within pre-hospital medicine, and really the learning curve, the steep learning curve of what took place in the events of 2014, and really the morbidity and mortality that just skyrocketed as a result of Russian invasion of the Donbass and annexation of Crimea.
So in 2014, it was the start of the war, and you were then working for OSCE.
No, well, actually, so in 2014, I was in Ireland, and I was working as a middle grade doctor in Ireland, and I was asked in spring. So everything sort of started in December of 2013. And then in January and February, everyone was on the streets in Maidan, and they started to do all these violent activities, including killing and murdering a lot of the protesters on the street. Very cold temperatures. It was absolutely horrendous. And by spring, I was requested by some colleagues that I'd worked with in the Middle East in the past to come and support with a health assessment. So I was tasked with the Ukrainian World Congress at the time in 2014 to do a health assessment, and that was supported by the Ministry of Defense. And it was an amazing opportunity. I had carte blanche. I got to go throughout the entire eastern section under attack and currently fighting, and be able to see a lot of the Role 1s and Role 2s at the time, really engage with the system, and really kind of help describe some of the needs and listen to a lot of the Ukrainian doctors and colleagues and say, what is it you guys need? What is it? What are you guys seeing, and what is going to benefit the most to reduce that preventive, that morbidity and mortality? And it culminated in a report, and actually a series of reports with colleagues. There's an American paramedic by the name of Patrick Chalou. It's open source information that you can find online, and he was very helpful and pivotal in being able to sort of navigate and push through a lot of these processes. And there's also colleagues on those reports, both Ukrainian and other international colleagues, that helped with a myriad of the sort of research base, which ended up being called the Medical ATO report. So ATO was the anti-terrorist operation. That was the initial operation in 2014 until about 2019, into just before COVID. And then COVID had sort of shifted into the Joint Forces operations. And then obviously now it is the full-scale defensive operations and counteroffensive operations. But OSCE, I started in OSCE. I was headhunted for that position as Chief Medical Officer and Acting Medical Director, Acting Medical Chief Medical Officer in 2020 for the COVID the COVID response, and of course was able to take all of those lessons from the unfortunately from 2014 into 2020, all of the issues and gaps and challenges in the pre-hospital space, and really push forward and try to accomplish some really groundbreaking stuff. And some stuff worked, some stuff didn't work. Got my hand slapped, almost got my hand chopped off a few times with some of the pre-hospital standards, trying to push forward. But it was a really great experience to be able to support in that process.
So you've had your irons in a lot of different fires in Ukraine. You've been trying to push for blood. You've been trying to push for T-TRIC. You've done a lot of publications on Ukraine, and you've been able to make headway. And there's various groups that you're part of to improve the outcomes of Ukraine. What have you seen as improvements from pre-conflict in 2013 to current pre-hospital care?
Yeah, excellent question. So TCCC, Tactical Combat Casualty Care, the paradigm, the nucleus, the nexus of point of injury, point of wounding care is now almost a household name inside Ukraine. There's a lot of different levels of standardization, something that I think NAEMT have done a great job over the last probably 10 months, over the last 15 years certainly, but over the last 10 months, they've gone like a rocket ship in being able to establish clear standards within Ukraine for tactical combat casualty care and tactical evacuation care, casualty care. The TECCC, the Tactical Evacuation Casualty Care guidelines were taken, and I took them off the open source NAEMT website, and I asked the medical director at the time. I said, "Listen, I'm at OSCE, and I'd like to present this as official OSCE clinical guidelines, with the idea that as new guidelines come up, it would be updated." And he said, "Well, it's open source. You're allowed to kind of do with it as you will. You're allowed to use it in academic sense. You just can't sell or make money off of it. Of course, OSCE is a nonprofit, intergovernmental organization, so they don't make any profit." And so some of the language had to change. Anything with the word tactical had to be removed, and the blood is there, morphine was there, the other advanced interventions were there. And I said, well, listen, if we take this and we can actually push this through the Ministry of Foreign Affairs, which is one of the main conduits that OSCE used, we could actually make this clear clinical governance for the purposes of all the paramedics that work. There was a paramedic contractor with sometimes well over 80 paramedics in country serving mission members for emergency medicine and pre-hospital emergency medical care, and really trying to push and drive that. And also within those guidelines are rapid access to blood. So really it was kind of trying to push this standard forward. Now, we got very far with it. It was kind of batted down quite a bit. It was partially accepted in some instances, but it was the first sort of stamp of trying to clear clinical governance guidelines that include blood, that include advanced pharmacotherapy for pain management, and including antibiotics in the pre-hospital space. One of the first, anyway. Obviously, there was mixed reviews. Some stuff worked, some stuff didn't work, and but that was sort of the first start of some of the pushing down boundaries of trying to get best practices out in the pre-hospital space in Ukraine.
So blood has just been authorized at the governmental level. Tell us the experience you had and what had to be put into place to finally get blood accepted in pre-hospital environments.
Yeah, the blood program and history inside Ukraine is a challenge across the board. The clinical practice guidelines that you can find on deployed medicine are all translated. About 92 or 95% of the entire deployed medicine website has been translated into Ukrainian and is now on tccc.org.ua. I believe that's the website, and it's an amazing resource. And they have blood, and they have all of these these videos that are all translated, and you can really learn a whole lot and really get an idea of the importance of blood and how to give blood in the pre-hospital space. But when Russia invaded in 2022, in February 24th, it was technically illegal for a non-hematologist doctor to go out into the pre-hospital space and provide blood, even universal donor. So initially, the clinical practice guidelines were given. We provided them to the Ministry of Health. We said, listen, this has to become a law. And the language is very clear. The summary page, in fact, it was basically copy and pasted and put into Ukrainian, and that law was passed. However, at the very last moment, someone removed the concept of it being pre-hospital. And so it was a bit wishy-washy. It wasn't very clear policy language. And that was I think, on March 6th of 2022. So essentially, less than 2 or 3 weeks after the full-scale, large-scale combat operation of Russian invasion of Ukraine. And there had to be subsequent 5 additional laws and mandates put forward by the government to actually make it such that no one else could challenge anymore these paradigms, these concepts of providing blood in the pre-hospital space, so outside of a hospital, outside the walls of a hospital, and B, by a non-hematologist, non-doctor, C, by a person who has just received this training and is not a certified paramedic or a certified felcher or a certified nurse, etc. So if you receive training in blood, you can give blood in the pre-hospital space. It is a challenge. The language is very challenging, the language of the law. It is very new, despite Ukraine being in martial law. There are a lot of Ukrainian healthcare providers and lawmakers that still do not accept this, and they're still bucking this trend and challenging this concept, even sowing seeds of doubt of the benefits of blood products, and other aspects of damage control resuscitation and how life-saving they are. They're actually trying to sow seeds of doubt. So those voices still remain a challenge, although there's fewer of them now than there were in 2014 and 2015. But a lot of things have been overcome. Blood is provided right now in the pre-hospital space, and is provided by those that are not trained hematologist consultants, that are combat medics. There are a raft of training programs right now providing excellence in training for pre-hospital blood, identifying the need for blood and blood in the pre-hospital space, which may sound relatively simple, but obviously being able to clinically identify those patients that will benefit from it, and having the resource to provide it, as well as the logistical system. There are colleagues at it's referred to as the Transfusiology Center of Excellence in Ukraine, and they have lifted mountains, being able to provide not only logistical support, but also a system, a framework, so that units can actually request blood, and they have a logistical supply chain to get universal donor O negative, and also providing low titer O whole blood, which is really new in the pre-hospital space in Ukraine. It is life-saving. The data is overwhelming. There are obviously, there are simple biological checks that you have to do, just sort of simple questions and things. But being able to provide this in the pre-hospital space is going to be an absolute game changer. And all of the resources we have available to hand need to not only provide basic life support, which is found in TCCC, good, well-trained, certified, appropriately trained people in TCCC, found in the NAEMT centers that are in Ukraine. Removing a lot of the myths, removing a lot of the shortcomings in some of the previous training that has taken place, but also being able to really provide damage control resuscitation with blood to hand, as close to point of injury and point of wounding, if not at point of injury and point of wounding, as possible.
And you've set up a logistic pathway for low titer O neg blood to be shipped from Western Europe.
Well, yes, I can't take credit for everything, but so low titer O, the preparation of low titer O is something that I put in the Transfusiology Center head, basically in contact with the people that do it at Department of Defense, so they were able to get the methodology and the preparation models, but also B, being able to offer, and the Germans, the Czech Republic, Romania, and Poland have offered several thousands of units of O negative blood, both publicly and privately, saying we are willing to prepare this and send this to you logistically. Now that has not entirely come to fruition, but that is offered, it's on the table, and I've been trying to put those two parties in the same room together so that they can establish that. Within the low titer O whole blood, we had a working group we initiated in spring, probably March of 2022, late March, early April of 2022, with deputy ministers of health and other colleagues and other subject matter experts, and said, listen, this is really important. How can we push this forward and get this brought to bear? One of the, obviously a lot of the papers that we've published have commented on blood and the need for blood, the benefits of blood. Obviously, not everyone needs blood in the pre-hospital space, and not everyone that has suffered trauma requires blood, but those that do need to be identified quickly and receive it. So yes, in the low titer O blood, we were able to really, to be honest, it was low hanging fruit. Being able to say, listen, there's a gap. You don't have enough universal O. The logistical supply chain is a challenge. Low titer O may be able to fill that gap to some degree, and just push it up the chain as much as possible. Make it legal. Make it so that combat medics can do it, and really push that as far forward and as far as close to point of injury and point of wounding as possible. And it's still an upward challenge. It's not a solved problem set just yet, but hopefully within the next within the next 3 to 4 months, it will become standard practice in Ukraine, and it will be a clear scope of practice for the pre-hospital combat medic, paramedic, and other medic providers in Ukraine.
That's brilliant, and it's been in effect for a couple of weeks, and now we have to look at the logistics of getting blood there, storage of blood, a disposal of blood that's out of date. And on top of that, there's other drugs you need when you give drugs, like calcium gluconate. Yesterday, you said calcium gluconate was your choice, and you said something about having a 3-drug mix available to the guys on the ground. Can you explain that, please?
Yeah, absolutely. So our colleagues at the Institute of Surgical Research, based at BAMC at the Brooke Army Medical Center, are looking at really what are the benefits of providing for all those patients that will likely require or do actively require blood, but we do not have blood to hand to be able to give to those patients just now. They're looking at a albumin, calcium gluconate, as opposed to calcium chloride, with the idea that it just has a better bioavailability and it's a little bit easier with IV or IO, and being able to provide the TXA, albumin, and calcium. And so if you can provide those 3 drugs, really in any modality, obviously the logistics is easier if you get it all into one line. Being able to provide that before a patient actually receives blood may be life-saving. Obviously, it's very important that clinical record keeping, and whether it's electronic medical record keeping or a TCCC card, clearly documents which patients have received this based on the mechanism of injury, based on the clinical presentation, and based on the observations or the vital signs, and then being able to say, okay, this is what they've received at this time. What are they like now? What are they like clinically now? And if we have a limited supply of blood, because as you point out, the logistics are very challenging in the pre-hospital space for blood, we may have to triage who actually gets that blood. And if we know some patients have already received albumin, calcium, and TXA, we may be able to prioritize and triage which patients, if we only have a finite resource of blood, and we can say, well, listen, these patients have already received some level of intervention, and clinically they're quite well. In comparison to these other patients who have not received this clinical intervention, we may be able to prioritize who gets blood over others. This is in a resource-poor environment, being able to prioritize patients and triage patients with which resources you have to hand. Not only, I mean, you commented on this before as well, being able to say, yes, TXA is important, albumin may be important. Obviously, calcium replacement is extremely important, but there's also the concept that, hey, we also need to be considering antibiotics. We also need to be considered additional rehydration, depending upon the time delay of medical evacuation, and we also need to be thinking about advanced pain management that's not going to adversely affect systolic blood pressure and things of this nature. So there's a lot of things, a lot of gaps that need to be addressed really as far forward as possible. But being able to provide blood is indeed life-saving, and something that we really need to be able to push for, as well as the adjuncts such as calcium replacement and TXA, etc.
Yeah, you had mentioned TXA as an IM instead of an IO. And I was teaching the Nordic SOCMs last week in Denmark. I noticed that they were giving TXA very quickly. They didn't quite understand the slow IV push. So would an IM TXA be a better option, or if they're crashed anyway, would that drug just stay in the muscle?
So excellent question. There have been a few publications relating to TXAIM, and Ukraine has a very interesting story because when we went in 2014 and 2015 during the assessment, they said, well, you're a doctor. Can you actually do some training as well? Of course, we'll do some training. We did some TCCC style training. And when we came back in 2015 and 2016, they said, listen, we understand, based on the TCCC guidelines and the CPGs that TXA is very important. So we trained a lot of our drivers to give these patients that are suffering catastrophic bleeding, not only tourniquets and other sorts of pressure dressings in keeping with TCCC standards, but also to give them TXA-IM, because we don't have access to train them IV. And actually, at the time, I think it was even illegal for an EMT to be able to provide an IV, as crazy as that sounds. And so they trained them all to say, listen, put the tourniquet on the battlefield, give them a jab of TXA-IM, throw them in the back of the truck, and keep moving, to clear the battlefield. And I said, well, I'm not really sure if TXA-IM is a thing. I don't know. So lo and behold, I call a few pharmaceutical companies and I said, well, listen, can this, Pfizer and others said, can this be given IM? And they said, well, we'll get back to you on that one. We're not really sure. And, about 3 different papers were published between 2017 and 2019, really looking at, in a pre-hospital space, pre-hospital environment, which has, colder environments, and obviously the coagulopathy and the hypothermia, and finding some of the benefits of being able to give high concentration, but low volume TXA preparations intramuscularly. And so the evidence is really there. If you do not have access to IV, or you do not have the ability for those that are providing rescue and clearing the battlefield to be able to give them training to do IV, being able to give it IM it does work. And it is something that more evidence will have to say whether or not it gets stuck in the muscle as it relates to the hypothermia. And obviously every patient will metabolize a little bit differently, but has an antifibrinolytic. TXA is very helpful for those suffering with catastrophic bleeding and other less catastrophic bleeding from trauma. So it's really it is life-saving, and it's something that intramuscularly it's used. I promote it intramuscularly right now based on the evidence that we have to hand. And I think as it relates to, the absorption, I don't really know. I don't know if it's going to be, if you have someone who is very hypothermic, if it's going to really just sit in the muscle and have a much less reabsorption. I don't know. I really don't know.
So all of the EpiPen studies from the Wilderness Medical Society, would that be equivalent to a TXA injection?
It's a completely different drug, as we do know. The bioavailability will be different. The pharmacokinetics will be different. There may be benefit of looking at that data, of getting a better understanding of saying, well, listen, if you do have a devitalized muscle tissue and you're giving intramuscular, what is really happening? Is it just going to sit in that muscle if you're devitalized and you have vascular insufficiency to that area due to hypothermia? That may be able to provide some level of help and interest with being able to get to the bottom of that. But it is a different drug. It's going to have different pharmacokinetics. It's going to have different absorption, and whether or not it's going to be able to be freely absorbed, I don't know. I don't know if that type of study would be able to answer that question.
So the 3 drug mix that you talked about was TXA, calcium gluconate, and albumin. Can you discuss the albumin? What's that for?
Yeah, so that's basically to increase the mean arterial pressure. If you have 200 milliliters of albumin and you have no access to blood, you have no access to blood products, you have no access to any other life-saving measure as it relates to volume. Albumin is a very good start. It has a very long shelf life. It's very affordable, and it may be able to increase. Now, the data is not out there yet, okay? But if you are able to give albumin, you may be able to increase the mean arterial pressure by a certain number of points long enough to be able to keep that perfusion enough to keep those end organ systems perfused enough to get that patient to a higher echelon of care where they can receive additional oxygen therapy, additional blood and blood product therapy, additional hypothermia therapy, and all the other aspects of damage control resuscitation and damage control surgery, with the idea that you're going to be able to increase that mean arterial pressure a few points to keep that end organ perfusion, to really reduce that shock and just keep that mean arterial pressure up just enough. Now, the data will be forthcoming, hopefully, from ISR, and be able to see, does that actually provide life-saving measures, and be able to understand, hey, what is the average mean arterial pressure increase and bump that it provides, if anything. It may not. There may be no difference whatsoever with fluid or no intervention at all. We have to look at that and see. There are a few studies that have been published relating to the use of albumin. The conclusions there are rather inconclusive, as most of it is hospital-based and surgical-based, as opposed to pre-hospital-based, dealing with that hypothermia as well as the hypovolemia. So, really, it's an outstanding question that needs to be answered. And I think in the pre-hospital environment, we want blood, we need blood. Give us the low titer O, give us the blood products. We understand that in trauma, but if we really don't have that in a large-scale combat operation, we may not have access. And we may need to consider alternatives, and the alternatives may be, albumin may play a role with those alternatives.
So albumin stays in the pipes for a while, doesn't it? It's a big protein molecule that doesn't get excreted very easily. How long does that increase the MAP?
Right now, it is very difficult to say based on renal perfusion and based on if we end up going with the pure 200 mLs based on what volemia loss. It really comes down to whether or not you can get that compressible hemorrhage under control, or if you have non-compressible hemorrhage, you may end up losing some of that drug out of wounds.
And the beauty of albumin, it's available in Ukraine nearly over the counter and cheap as chips. Very readily available. There's not a whole lot of pushback from the clinical community on the use of albumin, and so it's something that it may be a good adjunct. Now, again, we all are promoting blood. We would all like blood products, low titer O in the pre-hospital space, as far forward to point of injury as possible. But if we get to a point where we simply do not have resource and we are completely overwhelmed, we need to really start thinking about alternatives. And it can't be nothing. It can't be, hey, look, we want blood or nothing. And hey, this patient may actually benefit from blood directly. Let's do it. Or this patient doesn't necessarily need blood right now. We can push them to the next echelon of care with an intervention such as albumin and the others mentioned, like TXA, calcium, etc. Or the patient may need a different or alternative intervention. Really having those choices based in evidence is going to help dictate what we do with these patients, and most importantly, prioritize care so that we can reduce the preventable morbidity mortality as they're going through. Sometimes, as you pointed out, as a lot of people at this conference have pointed out, several hours, if not days, of evacuation time to definitive surgical care. So we have to be prepared for that, not only in eastern Ukraine. We have to be prepared for that on NATO's eastern flank. We need to be prepared for that in all of our respective national militaries and national governments for disaster response. And right now, we're simply not prepared. We don't have an alternative. So the blood is definitely what we want. Red stuff's coming out of the body. This red stuff is what we need to put back into the body. And it is brilliant that you and the community has put blood on the menu for Ukraine. And for those that aren't getting blood, then the possibility of albumin or other temporary options will help with MAP.
Well, having a clear logistical chain and a clear identifiable trauma registry to understand when patients receive blood, if that intervention helped or not, how much blood they received, and what their definitive outcomes were. That is the data that has been lacking for just about 10 years in Ukraine, unfortunately. Extremely limited data sets that we have to go off of, most qualitative in nature. And over the last 22 months, we simply do not have data on timelines. We understand evacuation timelines are very long. In some areas, it's 45 minutes to get to a surgeon. In some areas, it's 9 hours and 45 minutes to get to a surgeon. And in some instances, it's over well over 24 hours. So this inconsistency with the medical evacuation chain and getting from echelon to echelon of care, it is a challenge. It is a challenge for any nation to be invaded by a massive, huge military. So it's a very challenging environment indeed. But being able to make decisions based on evidence is what's required, and that evidence really comes down to data, and good data, not just qualitative sort of, oh, I saw this or I heard this. It has to be really rooted in hey, look, how many patients and what time did it take, and what was the outcomes, what were the clinical outcomes for these patients. And that's what's going to really help drive decision making for NATO partners, and most importantly, hopefully, for Ukraine to be able to make very good decisions about being able to provide blood as far forward as possible to point of injury and point of wounding.
So Ukraine has embraced the concept of blood. Let's push that to the next level. What is the current status of buddy transfusions and the Rolo program?
Sure. So the concept of the walking donor program was well accepted actually before COVID inside Ukraine, mostly within the soft community. Obviously, there are caveats. It's very important to have a clear understanding about bloodborne pathogens, and very important to have a lot of work done up front so that everyone clearly understands what their blood type is, and how it would work within a small unit of saying, okay, well, I understand that you can give to Joe, but Joe actually can't give to Mary because there may be a reaction there. So understanding all of that information up front is very important. Fast forward into large scale combat operations, and there was a lot of training that took place within the walking donor concept, and it's great. And obviously, a lot of risk benefit was weighed as it relates to saying, well, you may have hepatitis B, you may have hepatitis C, you may have something else, but actually you're going to literally die. So we're going to institute this walking donor because we understand that you're O negative. We've done the other bedside tests, and we understand this is going to be life saving. So this is certainly taking place right now. I took part in it myself. I gave blood at Roll Ones in the past. However, it is 100% completely unsustainable for large scale combat operations. Being able to say, listen, I'm going to take a unit out of Joe when we're dealing with 55 patients in a 24-hour period. If Joe gets hit, he is functioning at a much reduced physiological state. So here he is trying to be a rescuer. I'm going to take some blood out of him, one stinking unit. I'm going to take all that clinical resource, that time of dealing with 55 patients in a 24-hour period, and I'm going to say, okay, now we're going to have 2 or 3 rescuers just do this blood to get this one simple unit to give it to one patient. It's completely unsustainable. It's great for small units, and really understanding the process of hey, I understand that you've been tested. We're all on the same page. I understand what your blood type is, and we understand how we can interact with one another. Great. But when you're dealing with several 100 patients a day, and some in May and June of 2022, in one small area that I was dealing with, it was over 250 patients in a 24-hour period.
Wow.
At several locations. I mean, that's completely unsustainable to have a walking donor. You need to have several hundred, if not several thousand units of blood logistically prepared for these huge offensive operations, and you need to just keep pushing it as far forward into stabilization points, casualty collection points, and just get it readily available, universal donor or low titer O, when you're really scaling up for the need of offensive operations, which is when unfortunately offensive operations, you see just this massive spike of casualty counts. So that's basically it's a great program. It's excellent. Everyone loves it. It's great to train on. It's life-saving, certainly. However, for the purposes of massive casualties, it's simply not sustainable.
So, John, the last question I have for you is the tourniquets. So, Ukraine has been fantastic with TCCC training and getting tourniquet use. The problem is we're seeing tourniquets staying on for far too long, and 62% of amputations in eastern Ukraine are not needed because if the tourniquet had been repositioned or downgraded. What do you think the issue is, and how do we fix it?
Yeah, absolutely. Excellent question. Very prescient, super important. Full stop. Tourniquets save lives. We all understand that. We appreciate that. If you have catastrophic, life-threatening hemorrhage, tourniquets save lives. And in care under fire, it is very difficult for a practitioner, for a combat medic, and for a combatant to really discern, hey, is this indeed life-threatening or not? It's very difficult. So put the tourniquet on. Life-saving, put the tourniquet on. However, if the wound does not require a tourniquet, we don't need a tourniquet. We need to convert to a pressure dressing, as all of us know from TCCC. But we also need to be able to really assess, is even a pressure dressing required? What is the level of this wound? We need to assess it. And it does take training. It takes patient contacts. It takes the understanding of really what life-threatening, catastrophic bleeding looks like and is. I think this is something that during the huge uptick in Russian attack and invasion in February 2022, there were an absolute flood of volunteer trainers, which was great. And they were risking life and limb themselves to be able to provide training for a huge volunteer and conscripted warfighting cohort. However, it's also very easy to miss and to skip training elements such as conversion, or really being able to sink your teeth into tourniquet conversion. And as a result, in addition, coupled with the challenges of medical evacuation, several hours in some instances, you can be there for more than 24 hours waiting for medical evacuation without any training, or with absolute minimal training, and just not having the staff to be able to say, okay, look, we have 14 patients that are waiting underneath a bridge. How are we going to go and assess them? They all have a tourniquet on. They all receive. We're fighting 45 minutes ago. How are we going to assess them? We need to assign staff there. We need to have good military medical command and control, C2, to be able to understand where they are within the echelon, where they are with, where's the combat medic, who else is trained in combat medicine. And, this is going back to what NAEMT are trying to do with their TCCC training program, is really get an all combatant level, a baseline standard. And that baseline standard, well, it needs to address, hey, what is life-threatening catastrophic hemorrhage? What do we need to do to consider conversion? Which, as you look at the different echelons of TCCC, whether you're all combatant or all service member, ASM, and you go through combat medic corpsman, and you go through the other echelons throughout, it's very specific as who can really convert, because no one wants to take a tourniquet off and have a patient die in front of them. Obviously, we need to make sure that there's good training. We need to make sure that the tourniquet that has been applied is actually required. And the elephant in the room is we need to get that patient to a combat medic. If you haven't trained enough combat medics, or if you gave your combat medic 4 hours of training before deploying, that is going to be a challenge for that combat medic. They will have an inadequate amount of both capacity and capability to do what their job description is. They need longer training periods for the purposes of understanding combat medicine. They need standardized. Within the Military Medical Academy, needs to have clear, standardized guidelines. And if they have new ideas, which I think they do, and they should do, they can share that with the Committee for Tactical Combat Casualty Care. They can share these ideas, these concepts, these challenges, these lessons that they have learned with other partners, most importantly within the DoD structures, as it's one of the largest read resources found in deployed medicine, but also with other partners, and say, listen, this is the challenge that we're facing. It may be different than your coin operations in Iraq and Afghanistan. How can we join these two? How can we learn from one another?
So, John, what advice do you have for someone who wants to go help in Ukraine, or what can someone do to benefit what's happening?
Well, first and foremost, I think anyone that is willing and wanting to go to Ukraine, I certainly encourage it. I think it's excellent. It is dangerous, and you can die and you can lose limb. It is absolutely an extremely dangerous environment. Medics are targeted specifically just for being medical professionals. There is no Geneva Convention observed right now by Russian attacks at all. In fact, medics and medical and healthcare personnel are attacked and targeted specifically. Pete Reed, one combat medic, U.S. Marine, former U.S. Marine medic, was killed specifically for being a medic providing support. No weapon system of any kind, absolute targeted. Several other medics have been targeted and killed, and really suffering horrible consequences. So anyone who wants to get involved, I encourage, but I also encourage, it's very important to understand the risk benefit. Gone are the days where you just get your old medic stomp pack and get on a train and go to Kyiv and go onwards to Kramatorsk. Really understanding clinical governance is absolutely fundamental. So understanding, what is my qualification, what is my certification, is it transferable? Who do I need to speak to so I can understand what my scope of practice will be? There are several organizations, and I encourage everyone to engage with the World Health Organization Health Cluster, who have a consortium of a lot of groups and volunteers that are providing medical care, everything from rehabilitation and how to walk after significant injuries, all the way to frontline medical support at the zero line and everything in between. So really choosing where your expertise is and where you fit, being able to link with an organization that will provide for your own safety and will provide best practices within volunteer and humanitarian and non-governmental organization medicine is absolutely fundamental. And really understanding where you would fit within that paradigm and understanding how you'd be able to support. No one wants to be a burden when they deploy. No one wants to have any sort of sitting around on their thumbs and not really doing anything. You want to go to a good place. You want to go to a place with a good group that's going to support you and provide you with safety and your own health and safety aspects, and you want to be able to provide care. I think it's very important to understand, the UN and the World Health Organization have excellent resources online for volunteer medical workers to understand the risks about healthcare in danger. I believe the website is actually called Healthcare in Danger to that degree. And there's a lot of other online free resources that you can do before going into a conflict zone, so you can understand some of the basics of what to do in a high-risk security threat environment. And also there's the possibility of joining the military directly within Ukraine and going into that whole the process, the administrative process of being a foreign fighter, providing medical care inside the military. There's also the ability to be a volunteer within the Ministry of Health of Ukraine. So you go into a hospital, you get a letter from the medical director of the hospital, and they say, this person is a certified XYZ from this country, and we would like him or her to be a volunteer in our hospital. And unfortunately, the way the clinical governance works right now in Ukraine, the clinical governance only falls within that hospital, but being able to provide that for you, so that you have a clear understanding of what your clinical governance is, and you have a body to which you're answerable to. Don't think that you're going to be going to Ukraine and just, I'm going to go there and I'm going to do surgery and I'm going to do this and I'm going to do that. Well, you have a scope of practice, and you don't really want to go there to learn. You want to go there to provide support. You may learn as a result. Hopefully everyone is learning every day in pre-hospital medicine. I feel like I'm constantly learning every hour because there's too much stuff that I just don't know. But you don't go there for the purposes of learning. This is not a place, an environment to do that. You're going there to support and to help and render care and aid based on your scope of practice.
So, John, I've been chasing you down for months. I finally got a chance to get a chat with you and record this podcast. And I look forward to seeing you at our conference in February in Malta.
Thank you so much for the opportunity. And I truly appreciate the opportunity to speak and to share my experience.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.